In this video, we're going to be showing you a minimally edited video narrated of a standard cataract surgery. So first you see the creation of a 1mm paracentesis. Next you see the injection of 1% non-preserved lidocaine into the anterior chamber. There's already been piperacane and usually lidocaine gel used for anesthesia. Following this is a dispersive viscoelastic that is used to protect the corneal endothelium during the operation. Following this, we'll be creating the main incision, and this is created at the temporal limbus and is approximately 2.4 millimeters in size. This will create access for the removal of the cataract. So with these two incisions, we've now set up the main incisions in the cornea. Here we've inserted a bent needle cystotome and we're making an incision in the anterior capsule. And here we're creating a continuous curvilinear capsulorhexis, in other words, a circular opening in which to access the cataract and remove its contents and place the future intraocular lens. It is very important that the capsulorhexis is sized appropriately and generally is between 5 to 6 millimeters in diameter. The successful creation of the capsulorhexis is one of the cornerstones of modern cataract surgery. This can be done in a variety of fashions, but this is completed in this video with a manual forceps. And you'll be able to note the circularity and centration at the end of the procedure. Here, a balanced salt solution is used to loosen the cataract. This is considered the hydrodissection step. And now hydrodelineation or further balanced salt solution is used to loosen the cortex. You can see the golden ring sign as evidenced by the yellow ring around where the iris is. Now we are rotating the cataract to ensure that it's free of the capsular cortical connections. Additional viscoelastic is then applied both inside as well as on top of the cornea. This will ensure that the cornea is well protected. Now we're inserting the phacoemulsification handpiece. And so this is placed in continuous irrigation. And this is moving at 40,000 times a second. So this is really what the phacoemulsification procedure is. We're basically breaking the cataract into very small microscopic pieces. And this is how we're able to remove a 9mm lens, which is 5 millimeters in thickness, through a 2.4 millimeter incision. So now we've created a central groove, and the role of this one here is to break that cataract into smaller pieces. The harder the nucleus, the more pieces we need to break this up into. It appears that this seems to be freeing fairly well, and so we're going to be using the stop and chop maneuver to create 4 quadrants. Here we're using a horizontal chop maneuver to basically break it into 3 pieces. So each heminuclei or half nucleus is then broken into another half. So now we've created 4 pieces. We're changing modes and then we're removing each one of these pieces in turn. So this is during the quadrant removal step, and you can see that the material is actually falling very well into the tip of that phacoemulsification handpiece, and so it's removing some of that material. Our goal is to try to remove the material with using as little machine energy as possible, because this can create a lot of energy with the needle moving, as we said, 40,000 times a second. And so we're moving these pieces very carefully to try to avoid excessive movement, vibration, and energy that can irreparably damage both the cornea as well as the lens bag where that intraocular lens is going to be. We have removed the endonucleus, and now we're preparing to remove the epinucleus. This epinuclear shell provides some protection for the capsular bag, and so we generally like to remove this after the harder endonucleus has been removed. It's important at this time to slow down the procedure because it is really important to maintain the structural integrity of the capsular bag. And so you can see here the epinuclear shell is being teased away and removed slowly and judiciously. We're also keeping in mind that the patient can feel some of these small movements. Even though there's anesthesia, they can still feel the small movements of these instruments, but this is generally very well tolerated and anesthesia is very effective. So we've withdrawn the phacoemulsification handpiece, and now we're preparing for irrigation and aspiration of that remaining bag. So this is really the cleanup step to prepare for the placement of the new lens. And so here the irrigation aspiration handpiece looks quite different. It doesn't have the bare metal that we saw on the phacoemulsification handpiece. That little gray tip is the so-called polymer tip. This is very safe, very so-called capsule friendly, and it's very unlikely to rupture the capsular bag with this instrument. And we can use this to try to remove some of the lens epithelial cells, and this will help to prevent capsular contraction and phimosis. In other words, we want some scarring to retain the lens, but not an excessive amount of scar tissue that might cause problems later. So here we're polishing both the posterior as well as the anterior capsules. And once we've done this to our satisfaction, each of these steps is quite critical, as the artificial intraocular lens will be retained in the eye indefinitely. These lenses are not currently designed to be interchangeable. We've turned off the microscope light, and here we're inserting some additional viscoelastic to inflate the capsular bag and prepare for the lens insertion. I have edited out the preparation of the intraocular lens. So here we actually see the insertion of the Rayner RAO 600C intraocular lens. And so this is inserted in one step directly into the capsular bag and unfolds very nicely. This lens is made in England and comes from the company that made the world's first intraocular lens. We can see the controlled insertion, and the lens is already in the bag, so we just need to rotate it. I prefer to have the lens in a vertical orientation for improved stability. Also takes into account that the eye is not completely symmetric. We're now injecting some antibiotic as well as steroid, so moxifloxacin as well as triamcinolone. Now we are removing some of that viscoelastic because we don't want to retain it in the eye. It can cause intraocular pressure spikes. So we're actually removing the viscoelastic from behind as well as in front of the lens. And we're also trying to remove any retained small microscopic pieces and ensuring that the lens centration as well as placement looks good. You can see how well centrated it is. We have some of the antibiotic and steroid seem to be coming back. And our job now is to hydrate the incisions. And here we're using balanced salt solution to hydrate the incisions and reform the anterior chamber. So we've hydrated the main incision, and now we'll be hydrating the paracentesis. We'll be clearing off the viscoelastic as part of the last part, but this shows you the complete, minimally edited standard cataract surgery procedure. Here we're just doing a little bit more cleanup, but I hope that this informational video has helped you understand a little bit more in terms of what is involved with cataract surgery. This is just the basis for many other variations of this cataract operation. I hope this has helped you understand this a little bit better. Thank you.